Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert about amyloid disease. And for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. And you may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, amyloidosis is a group of diseases in which abnormal proteins known as amyloid fibrils build up in various tissues, including the kidney, heart, liver, skin, and nervous system, resulting in a variety of clinical sequelae, including organ dysfunction and death. There are over 23 unrelated proteins known to form amyloid fibrils, many of which are aggregates of misfolded proteins that are neither biodegradable nor can be recycled by our bodies. Abnormal immunoglobulin light chains, known as AL, amyloid light chain, transport protein transthyretin, known as ATTR, which normally transports retinol and thyroxine, and amyloid A, that's AA, are some of the better recognized examples of amyloid proteins. It's important to note, however, that hereditary, dialysis-associated, localised and ocular forms also exist, and beta protein precursor is implicated in Alzheimer's syndrome, as are other amyloid fibrils in different dementia diagnoses. Well, the quoted incidence of amyloid disease is 12 per million, and it's estimated that over 20,000 cases of amyloid are undiagnosed and thus untreated in Australia alone. It's noteworthy that 13 to 17% of patients with heart failure and degenerative aortic stenosis have amyloidosis, and that up to 50% of patients with amyloid see 5 doctors before a diagnosis is made. Up until recently, only a 4-year life expectancy was anticipated. Unfortunately, pharmacological breakthroughs are expanding this horizon. So, along with Dr. Simon Gibbs from the Precision Hematology and Department of Clinical Hematology at Eastern Health in Melbourne, who's our guest today, and doctors like Nikki Bart from the Amyloid Centre St Vincent's in Sydney, our objective is to raise awareness of this condition nationally. Although the term amyloid was originally coined by German botanist Matthias Schleiden to describe the normal amylaceous component of plants, in 1854 Rudolf Virchow adopted the term to describe abnormal extracellular material seen in the liver during autopsy. As we'll explore in this podcast, we now think of amyloid disease in terms of primary systemic amyloid, AL disease, where a clone of abnormal plasma cells secretes excess immunoglobulin light chains that misfold and aggregate as non-biodegradable, non-recyclable amyloid fibrils. And such a clone is also observed in about 5% of myeloma diagnoses and about 12% of MGUS, which is the monoclonal gammopathy of uncertain significance. Additionally, age-associated amyloid transport transthyretin protein, ATTR, is an acute phase reactant produced predominantly in the liver in response to multiple cytokines, which may become amyloid in form with senescence, depositing in the heart and kidneys where diastolic dysfunction and renal impairment develop. A secondary systemic amyloid, AA disease, is associated with chronic inflammatory diseases such as rheumatoid arthritis and Crohn's disease, as well as familial Mediterranean fever, for example. Well, in this podcast, I was curious to explore how we can improve our surveillance for this condition and to raise our awareness. I was also keen to understand how to confirm the diagnosis and to explore treatment options, including proteasome inhibitors that block the breakdown of proteins within amyloid-producing plasma cells, effectively poisoning them, monoclonal antibodies that kill abnormal light chain-producing plasma cells, emerging immunotherapies that may help clear amyloid proteins, as well as drugs that interfere with amyloid protein formation, chemotherapy, and stem cell transplantation. The subject is certainly an emerging field of great interest, especially as site-specific amyloid protein deposition may have a major impact on dementia and senile-associated deaths and heart failure. To explore this interesting area further, please welcome to the podcast Dr. Simon Gibbs from Precision Hematology, who is a clinical hematologist and amyloidosis specialist and a senior adjunct lecturer at Monash University. So after attaining his medical degrees from the University of Melbourne, he moved to Cambridge in the United Kingdom to gain further experience in autologous and allogeneic bone marrow transplantation as treatment for myeloma and leukemia. And he completed the 4-year fellowship at the National Amyloidosis Centre at University College London, focusing on novel therapies for AL amyloidosis. Upon returning to Australia, he was appointed the myeloma lead at Eastern Health and established the Victorian and Tasmanian Amyloidosis Service, the VTAS. He's the chair of the Australian Amyloidosis Network and a member of the Haematology Society of Australia and New Zealand. He serves on both the Educational Subcommittee for the International Society of Amyloidosis and the Medical and Scientific Advisory Committee for Myeloma Australia, and he's the author of over 40 publications in international medical literature. So please welcome Simon to the podcast. Dr. Simon Gibbs, haematologist, a specialist in amyloid, who I've had the great privilege of referring patients to, and you've got us out of a lot of difficult diagnoses. Thank you very much, and so nice to have you in Melbourne, and I really do appreciate you joining me on Everyday Medicine, Simon. And I'm sorry to have hassled you and troubled you when you're in Bali, in Ubud.
No. Look, it's a great pleasure. It's a great pleasure. Thank you so much for the invitation.
Well, we want to talk about amyloid, but I always like to ask guests about their journey, and I'm just intrigued as how you become so specialised. I understand you're across haematology generally, but this is a big special interest, and you're known as the person to approach when there are difficult amyloid cases in Victoria, and possibly right across Australia. Tell us about your journey, Simon. How did you get here?
Sure. So I knew I wanted to be a physician, and I really enjoyed general medicine, and look at all the different organ subtypes. But general medicine was sort of going off a little bit when I was sort of deciding what to do as a specialist trainee. And I had a really inspiring registrar when I was a junior doctor, Andrew Way, who's become a leukemia guru. And I really enjoyed spending time with my patients and getting to know them and going through all their problems. And so I decided to do haematology, which I always found is a really fascinating and constantly changing, constantly evolving area. And then in my first year, as a advanced trainee, I was at Peter MacCallum Cancer Centre, and we had a patient with AL amyloidosis. And I think it's fair to say that he had a really horrific death. And, AL amyloidosis, we'd seen a couple, but this guy died really, unfortunately, with recurrent tachyarrhythmias. And I just remember my medical student lecture by Colin Masters at University of Melbourne. And I thought, this is a horrendous, awful disease. There's no treatment. We don't understand what goes on. People just die really quickly. And so when this poor guy came in, and he had a transplant and then developed all these arrhythmias, and it was just a horrible, horrible way to go, I sort of thought, I really, really hate treating this disease. And then I had an opportunity to do my last year of training in Cambridge and in the UK. But before I left, I was told I should try and bring back a specialty or a niche or some sort of skill. And while I was there, I saw a couple of patients who had been seen at the National Amyloidosis Centre in London, and they would send back these 3-page reports that were really clear, made sense, logical, and I started to develop an understanding of this really scary disease. And then I thought, maybe I could even just work there for a bit, get a bit more of an understanding. And so I went down and visited the centre in London, and fortunately they offered me a job, and I just found it a really fascinating disease that involved a lot of different organ systems, a lot of different specialties. So it sort of linked into my original idea of doing general medicine, yet being academically fascinating and challenging. So there's never a dull day in an amyloid clinic. And that sort of, I decided to work at the National Amyloidosis Centre for 5 years. And then in 2014, I came back to Australia, and we thought we'd set up something similar here. It's all these amyloid patients came out of the woodwork then.
Well, I think it's been hugely successful, and certainly it gets us out of some real difficulties in other specialty medicines and general medicine. So thank you for doing that. And I'm interested to know, like, how common amyloid is. I'm told that it often takes about 5 doctors before a diagnosis is made.
We're getting better.
We're getting better. And there are many undiagnosed cases that are presenting perhaps with heart failure and renal failure and so forth that are in a community. So I'm sure you're going to tell us a little bit more about this. How common is it?
It's a great question. We know that we will all develop amyloidosis if we live long enough. I think if we all live to 150, we'll all get it. So I think protein misfolding associated with amyloidosis is a natural part of aging once we get to a certain point. So there's AL amyloidosis, which is related to myeloma, which is how me as a hematologist got involved. But far more commonly is ATTR amyloidosis. And that's a disease typically affecting older white men. And they often present with carpal tunnel syndrome, and then about 5 to 10 years later, they develop restrictive cardiomyopathy and heart failure symptoms. And it's estimated that up to 30,000 people in Australia actually have ATTR amyloidosis. So cardiologists are increasingly seeing this. Pharma are certainly increasingly interested because they can smell, a profit opportunity, which is great for our patients because now we're getting drugs and trials developed. So we think that there's probably about 30,000 people in Australia with ATTR. We think that there's probably about 60 newly diagnosed AL amyloidosis patients, at a minimum in Australia per year. So, there's usually at least one new diagnosis a week, and patients are living longer, which is great. And then you've got the rarer hereditary forms and secondary or AA amyloidosis, which is much less common these days. That's the one where you've got to have a chronic condition for 15 years or so, and then you can develop renal failure from amyloid. But with new biologics, et cetera, what we're seeing is that's a sort of dying disease, fortunately. But with an aging population, we're seeing a lot more ATTR amyloidosis. So,
can I tackle you on that one? So that's the transthyretin.
Transthyretin. Yeah.
So where is that protein? I want to ask you where that. Like I've always thought of amyloid mostly as being like abnormal plasma cells producing the light chains. We're talking about something different here. And where's this protein coming from exactly?
Sure. So transthyretin is made, about 98% of it's made in the liver. There's a little bit made in the retina and one or two other little places, but essentially the liver. And it's a carrier protein. It carries retinol and thyroxine, and it is inherently amyloidogenic. So as we get older, this carrier protein misfolds, and then by misfolding, it begins to aggregate and make amyloid fibrils that deposit in the carpal tunnels. Typically, we tend to see it in people who have used their hands a lot. So people like mechanics, carpenters, farmers, sports people. We sort of see that in. So if a man is over 60 and he's had bilateral carpal tunnel releases, you really have to look for amyloid because it's very, very associated with it. And with bone scintigraphy, so what we used to use for, what we still use to look for secondary solid organ malignancies, we can use that, and certain traces will actually be taken up and bound by the amyloid fibrils within the heart. So about 30 years ago, we had a group of Norwegian neurologists did a whole series of bone scintigraphy on their prostate cancer patients, and typically an older, whiter male population. And what they found was that a small percentage of them had their hearts lighting up like a Christmas tree, and biopsies indicated that it was amyloid. And fast forward 20 years, and now it's being used around the world as a really, really helpful diagnostic tool to diagnose that. ATTR amyloidosis has really only been recognised for the past 30 years or so, and thought to be an extremely rare disorder until the last 15, 20 years, when we've realised it's far, far, far more common than what we ever appreciated. And what was thought as hypertensive heart disease or diastolic dysfunction of the elderly, etc., is actually a pathological process, which now we have treatments that can slow the deposition of amyloid. And there are trials with some really cool monoclonal antibodies that actually might be able to resorb the amyloid deposits within the heart, which is incredibly exciting.
So is that in relation to that ATTR we're talking about from the liver? It's a transport protein. Are we saying that with senescence, with aging, we have some change in the genetic code, and now we're getting a protein that just isn't it isn't taking its normal shape, it folds, then it binds to other transthyretin proteins and forms these fibrils that can't be degraded and can't be recycled, and then they're going to be deposited in the heart, kidneys, and nervous system and so forth. Okay.
Yeah. So the transthyretin actually is a tetramer that is within the bloodstream, and but as we age, what happens is that they can dissociate into individual monomers, and those individual monomers are inherently amyloidogenic and can misfold easily. So there's all sorts of, like, when we look at treatment of ATTR, we look at things that can actually hold the tetramer together, rather than dissociating amyloidogenic monomers.
So that's on one side of the amyloid kind of consideration. What about, the light chain disease that may or may not be associated with, as I understand it, with myeloma? But can you talk a little bit about that? Just enlighten us on that side of it. Then we'll come to the diagnosis.
Sure. So AL amyloidosis is where monoclonal immunoglobulin light chains kink or misfold. So with transthyretin, it's the transthyretin protein. With this one, it's like the kappa or the lambda serum-free light chains that are misfolding and aggregating together to make AL amyloidosis fibrils. So it's MGUS or myeloma with catastrophic extras. So the treatment has typically been what we've used for myeloma, and that's really only in the last 12 to 18 months that's really started to deviate from myeloma. So we know that there are certain myeloma treatments that are not suitable for AL amyloidosis patients. And we now have monoclonal antibodies in trials, which again, hopefully will remove the amyloid deposits. But importantly, whenever you are faced with anyone who potentially may have amyloidosis, we need to look for a plasma cell clone. So we need to look at the serum electrophoresis, the urine electrophoresis, looking for bench chains, proteinuria, and the serum-free light chains. If they're abnormal, we need a biopsy to really nail the subtype and the diagnosis of AL amyloidosis. And then we have a lot more options for chemotherapy treatment in that area. And the AL amyloidosis can affect lots of different organs. So it can be the heart, the liver, the bowel, the kidneys, autonomic peripheral nerves, and soft tissue. So the sort of classic stuff we learn in medical school, like macroglossia, periorbital bruising, etc. But the survival outcomes have significantly improved over the last 10 to 15 years due to the greater understanding of the disease, the pathogenesis, and the diagnostics, the fact we have serum-free light chain analysis these days, and also more clever novel therapies such as bortezomib, daratumumab, other chemotherapies that can target the plasma cells producing the amyloidogenic light chains.
So, Simon, not all myeloma will necessarily result in amyloid deposits. So do you see amyloid light chain disease as a sort of very specific variant of myeloma?
I almost see it as a complication. So we know that up to 15% of patients with myeloma will have some evidence of amyloid deposition. Now, it may be an incidental small deposit in the blood vessels of the bone marrow to sort of end-stage cardiac failure, end-stage renal failure, et cetera, et cetera. So 1 in 8 myeloma patients can have an amount, but in terms of a clinically meaningful amount that requires urgent treatment and specialist intervention, that's quite a small percentage. But in my practice, anyone who gets a bone marrow biopsy associated with plasma cell dyscrasia, whether it's an MGUS, smouldering, or symptomatic myeloma, they all get a Congo red. Because I don't want to miss an amyloid patient, because patients can go from 0 to 0 very, very quickly if they've got cardiac involvement or autonomic neuropathy, etc. So it's important that we patients up.
If that's a Congo red stain on the bone marrow biopsy, or
on the bone marrow trophine. So we always do a Congo red stain on the bone marrow trophine for anyone that we've done a bone marrow on for workup of myeloma. But the other target organ that we look at is the symptomatic organs. So if someone presents with renal impairment and proteinuria, we would always try to encourage our friendly nephrologist to go where the money is and do a kidney biopsy.
So I just want to back it up a little bit. So we've got these two big things, the light chain, we've got the transthyretin, which is, as we getting older. When the patients, how are the patients presenting to us? They may have someone who's got tunnel disease, which is perhaps bilateral, it's an older gentleman. Okay, we're going to start thinking of ATTR disease. If it's renal failure or restrictive cardiomyopathy, yes, there'll be other things, of course, we have to consider, but we have to start thinking about this condition as well. What is your normal sort of diagnostic workup? Like how are you working out the light chain disease? I know this is simplistic for you. Light chain ATTR. No. What are you doing? How can we, in primary practice, sort of hone in on this before we refer to the patients on to you?
I think probably the most an unexplained neuropathy. You've got to start thinking about amyloid, but much more common is patients present with pedal edema, shortness of breath, so signs of bog standard cardiac failure.
Yes.
And I think really we are getting a lot better, and the cardiologists are getting a lot better at looking at an echocardiogram, and the echoes are so much better these days than what they used to be, and the analyses that we can do are so much better. But if one has a thick-walled heart, don't immediately assume it's hypertension. You've got to go and say, well, what is the cause of this? So cardiac MRI and bone scintigraphy can be very, very helpful in that instance. As I sort of mentioned, if you've got a male over 60 with a history of carpal tunnel syndrome and you get symptoms, it's ATTR until proven otherwise. But likewise, you have to think, does this patient have an MGUS? Have we actually looked for a plasma cell clone? Can we biopsy something? What else is going on? And I think that nephrologists and cardiologists are increasingly aware that amyloidosis is a lot more common than what we thought, and it's sort of higher up now on the diagnostic algorithm of what potentially causes this.
In the electrophoretic, will we pick up the ATTR on that, or how do we specifically?
In the echocardiogram, did you say?
Oh, no, electrophoretic. If you're doing serum protein electrophoretic.
Oh no, so patients with transthyretin amyloidosis typically don't have a plasma cell dyscrasia. They don't have an MGUS or a myeloma, so it's a completely separate protein, and so it's not related to a bone marrow disorder. So occasionally, it's frustrating because you can have a completely separate incidental MGUS or myeloma that's in no way related, because we know that the people who get myeloma and MGUS are typically men over the age of 65, which happens to match those who get ATTR amyloidosis. So it can be a little bit challenging, and there is an opportunity for actually getting the subtype wrong and giving the wrong treatment for the amyloid. And that's part of the reason why we set up the Australian Amyloidosis Service, to try and help other physicians make sure that we're getting the right subtype, we're getting the right treatment to the right patients, and we're bringing clinical trials and novel therapeutics to the country.
What is the serum test you order for the ATTR?
So there is no blood test that you can actually order that will say this is ATTR. And this is why amyloid diagnostics are so complicated and difficult.
Right. Okay. Yeah.
Yeah. Bone scintigraphy with a good echocardiogram and a plasma cell screen is really what you need to do to make the diagnosis. So if you've got cardiac uptake on bone scintigraphy with CT SPECT that demonstrates it's in the walls, a suggestive echocardiogram showing thickened heart walls, typically with the APC spared from the thickening. Elevated cardiac biomarkers, so the NT-proBNP and the troponin T. If you've got someone who's got persistently elevated troponin, big red flag for amyloid.
Yeah.
We used to talk about, small curious complexes on an ECG, which is a hint, but it's by no means sensitive or specific. So, but I think that if you have someone who has a thick-walled heart and they've got cardiac failure, especially if they're a little bit older, you have to think about amyloid. So we need a blood test that says, yes, they've got amyloid, but we haven't quite got there yet, Luke. So,
yes,
yeah.
okay. No, I'm there. It used to be also the recommendation you do a rectal biopsy and, I'll ask that, or a fat pad abdominal fat biopsy. Are we still doing those? We don't need to do that now. We've got those other approaches.
No, I used to do a lot of them, and I'm increasingly not doing them, because what I tend to find is if you do a fat pad biopsy or a rectal biopsy, you often, sometimes you can pick up that there's Congo red positivity, but it's actually quite difficult to subtype on that screening tissue. And so what you often have to do is you still have to go on and do a bone marrow biopsy or do a biopsy of the organ of interest. Right. So I think bone scintigraphy has really helped, because we know that we can diagnose ATTR amyloidosis if there's cardiac uptake on bone scintigraphy, plus no positive plasma cell screen. So if the serum electrophoresis is normal, if the serum free light chains are normal, if the urine electrophoresis is normal, but if there's a suggestive echo uptake in the heart, then you don't need the biopsy. You can say, okay, this is ATTR, and I would then speak to an AN service about whether there's a trial available, or what would be the best sort of anti-amyloid therapy for that patient. But if we do detect a plasma cell dyscrose, if we do have like a paraprotein or elevated serum free light chains, we then still have to go on and do a diagnostic biopsy. So, and then those biopsies can be helpful in ones where things just don't add up, because we still have those rare forms like secondary or AA amyloidosis, hereditary forms, penetrance is variable, so there's not always a family history. And I think really, if someone's got like quite a significant peripheral autonomic neuropathy, that rings alarm bells to me that this could be hereditary.
Okay. I want to ask you a bit about the secondary forms related to chronic inflammatory diseases. But before I do, here's a question that is probably very simplistic. But we've got all this in the AL amyloid. We've got light chains being pushed out of plasma cells, abnormal kinds of plasma cells. What about the heavy chains? Now, presumably they're not amyloidogenic, but are they pushing them out as well, and they're just getting excreted? What happens there? Or is it just light chains that are being manufactured?
Yeah, it really does seem to be light chains are the problem. There is a phenomenon called amyloid heavy chain disease. It is very, very rare. It usually is very slowly progressive renal involvement, but like I've probably seen a handful of cases in my career. Really, the money is in the light chains. Okay. Not so much if it's an IgM. That there is a particular subtype of AL amyloidosis which is associated with an IgM, sort of like a Waldenstrom's, where you're more likely to get a high paraprotein and not so much of the light chains causing the problem. But again, that's a sort of 1 in a million sort of patient. But I think the main thing is just making sure that if you think someone's got ATTR amyloidosis, you've still got to order the light chains. And I think one of the things that I find a bit frustrating is you get bone scintigraphy reports and they say this is consistent with ATTR amyloidosis. And it's like, well, yeah, it is, but you haven't excluded AL, because we know a third of patients with AL amyloidosis with heart involvement with AL will still have a positive bone scan. So you still have to, unfortunately, with every patient, you've still got to send off the serum electrophoresis, urine electrophoresis light chains. And if people aren't sure what to do, the details should be on the Australian Amyloidosis Network's website. So this is a shameless plug, www.aan.org.au. There are some contact details if you need to speak to anyone about, am I doing the right thing, or what else should I be doing? And there's also some sort of handy hints and things like that on the website. It's a great resource for patients. Fantastic.
Yeah. Perfect. Well, tell us a little bit about the secondary. What do we need to know about secondary amyloid?
So typically secondary amyloidosis is mainly a renal disorder. So it's something where patients will get nephrotic range proteinuria associated with renal impairment on a background of chronic inflammation. So when we're talking there about things like rheumatoid arthritis, Crohn's disease, bronchiectasis, or things such as familial Mediterranean fever, where they get sort of these recurrent attacks once a month. or several times a month. So the main thing is that when I see anyone with isolated renal amyloid, the first thing I sort of ask is, do you have an autoimmune condition? What's your medication list? Are you on hydroxychloroquine, for instance, or is there something else going on? Then I ask about have you got any chronic infections, TB, exposure, evidence of any bronchiectasis. But we're probably now seeing only about 1 or 2 new AA amyloid patients a year now, whereas we're getting referred 1 new ATTR amyloidosis a week now.
Yeah.
So
because chronic inflammation has been better controlled.
Yeah. But the chronic inflammation, I mean, look, it can be there for a very short period of time, like or 2 years, but typically it's about 15 years of suboptimally controlled inflammation.
Yes. Yeah. And that's diagnosed, we mentioned proteinuria, diagnosed by a biopsy and exclusion of other forms of amyloid. Okay.
Yeah. We're doing immunohistochemistry. And in difficult cases, you can send off for mass spectrometry. So they actually individually laser microdissect out the amyloid fibrils, put it through the mass spectrometer, and actually it'll tell you what the predominant precursor protein is. So that's the way that we do the subtype, is which protein is actually kinked or misfolded to cause this. And so SAA, so we call it AA amyloidosis for secondary. SAA is a sister protein to CRP. So that's the one that's kinking and misfolding and causing the amyloid deposition in the kidneys.
Yeah, it's fascinating.
It is.
We've got, when we come to treatment, of course, the treatment is going to be different for plasma clone disease AL than it is going to be for the transthyretin. Can you give us a little bit of an update on what we should know, what new things we should know about? Maybe treat them differently in our discussions. Do you want to talk about that first?
So I mean, AL amyloidosis is we do use a lot of myeloma type therapies. Yeah. So proteasome inhibitors like bortezomib, anti-CD38, monoclonal antibodies like daratumumab or isatuximab. So daratumumab has really revolutionized the treatment of AL amyloidosis. We've seen much higher complete response rates and remissions. Patients are living longer in regaining organ function. So it's really been a game changer. The holy grail is to get a monoclonal antibody that can actually remove amyloid from organs. And there are 2 trials currently running looking at that. I think we're getting very, very close. In ATTR amyloidosis, there are a number of really exciting treatments that are coming on board. So we have TTR stabilizers. So these are usually oral medications that can bind the TTR and try to stabilize it in its tetrameric form, so it doesn't dissociate into the amyloidogenic monomeric forms. The cheapest and easiest to get in this country is diflunisal, which used to be called Dolobit. It's an old anti-inflammatory, but it actually has the anatomical properties of being a stabilizer. And we've got about 150 patients on that at the moment. We have to look, obviously being a non-steroidal, we have to look at kidney function and making sure they're on a PPI to make sure they don't get like an ulcer. But we now have tafamidis and acoramidis, which are 2 other stabilizers, oral stabilizers that have been proven to be effective. They're not yet available in this country, but hopefully they will be soon on the PBS, fingers and toes crossed. Then we have things like gene silencers or gene knockouts that, such as patisiran and inotersen and other sort of second generation molecules, which actually tell the genes to decrease how much transthyretin is actually being produced. So we know that we can function perfectly well with only 10% of our transthyretin. So if we can knock that down 80, 90%, we essentially stop or really slow down the progression of the disease. So again, that's been proven to be effective compared to placebo, and we're waiting on a PBAC decision about whether we can get patisiran in Australia. And then again, lastly, recently published, a monoclonal antibody has definitely been shown in phase 1 studies to actually cause amyloid resorption. So by hopefully the end of the year, early next year, there will be a clinical trial, and I think there's 5 or 6 sites in Australia looking at a monoclonal antibody to remove amyloid deposits in ATTR. So this is something that, was seen as once you got diagnosed, you had a 2 to 6, maybe 8 years survival maximum. And the first couple of years aren't too bad, and then you deteriorate into really quite crippling cardiac failure. But to actually have something that can reverse that now, potentially is extremely exciting. And then last but not least, we have CRISPR coming along in a trial. So looking at actually cutting out and putting in a different TTR gene, one that doesn't actually release so much TTR, and hopefully, again, turn things off. And if you have a hereditary form, we might be able to completely alleviate patients of their disease. And so it's an incredibly exciting time for ATTR patients, because there are a lot of really good trials out there. And I would always encourage all ATTR patients to, again, have a look at the website, or at least come for one consult with an amyloid service. And then lastly, when it comes to the secondary amyloid, the AA amyloid, we need to treat the cause of the inflammation. So if patients have rheumatoid arthritis and their CRPs are always in the 20s, 30s, 80s, we need to up the ante on the biologics. Or if they have familial Mediterranean fever, we need to put them on a decent dose of colchicine, or try other medications like anakinra or canakinumab, things that will actually decrease IL-6, IL-1, those sorts of inflammatory cytokines that can drive SAA levels up and drive the amyloidogenic process.
Yeah, that's a fascinating expose of that, Simon. It is very exciting. It does seem to me as though hematology is at the vanguard and cutting edge of a lot of sort of new cellular therapies, which then filter out to other fields of medicine. Like there's a lot of things you covered there. Changing proteins have been produced and reabsorbed. That's amazing.
Yeah, I'm a bit biased. I'm not going to say that hematology isn't great. So,
well, it's very exciting, and I guess we've got an aging population. So, I didn't appreciate the importance of that transthyretin and protein. I did not appreciate that. So that's been a big eye opener for me. Yeah. I've really just focused my whole mind on the AL, because that's what seems to be in textbooks and what I learned when I was younger.
I think also AL's scary. Like, if you get a new AL amyloidosis that can be running 6 months ago, and now they're gasping for breath to go to the toilet, and these patients can have pretty horrific deaths. So we know even now that 10 to 20% of patients who present with significant cardiac failure in AL amyloidosis won't make it, despite all these advances. But if you survive the first 6 months, then your outlook is really, really bright. And that's why I would always say it's not trying to get more business, because Lord knows I have enough. But, I do think if you've got a challenging AL amyloidosis patient, that's why we set up the Australian Amyloidosis Network, is to sort of work with the treating physicians to try and help out, bring novel therapies, bring clinical trials to Australia, because for a long time Australia was left off the map with these trials, and I think that's changing now, which is really exciting.
Well, Simon, look, thank you very much. You really, brought us up to speed on this very interesting diagnosis, and I think it's about raising awareness, which you have done very, very beautifully, and it certainly will change the way I approach some of my clinical problems, because I certainly have missed this diagnosis before, rather ashamedly.
Yeah, we all have. Don't worry, you're not alone.
Just one other word, a word of advice for a young doctor, maybe contemplating a career in haematology. What would you say? What would be the best advice you could give that doctor?
Run. No. I think haematology is really, really interesting, and it's a really amazing specialty in that you've got such a choice. You can do the bone marrow yourself, prepare the slides, look at it under a microscope, diagnose the leukemia yourself, then go and tell the patient and write up the chemotherapy and walk with your patient through the journey. And so you get to know your patients really well, and you're really involved in the diagnostics, and you can choose to just do the diagnostics and never leave the lab, or you can purely be clinical, or you could be a mixture. So there's lots of opportunities, lots of research. going on. So it's a very broad specialty, and one that's constantly evolving with new therapies, new understandings of pathogenesis. So I never dreamed that I would end up doing amyloidosis for 75% of my working life. Now that's purely what I do. I do quite a bit of myeloma as well, but I don't do a lot of general hematology now because I've gone down this pathway. But likewise, I've got other friends who do all sorts of different things in hematology. So it's exciting, and you get to, like a lot of specialties, you get to travel to pretty exotic places to go to conferences and work with colleagues and those sorts of things. I'm off to Athens next month and San Diego in December. So it's a great specialty. So if anyone wants to do it, come and see me.
Well, that's well deserved, Simon. I really appreciate the time you've taken to speak to me tonight, and for your contributions to hematology and the amyloid world. And we really appreciate it, Simon. So thank you very much. Enjoy San Diego and Athens.
Thank you so much for your kind words. I really appreciate it.
I appreciate it very much, Simon. Thank you. Thank you for joining me on the podcast episode we've had today with Simon. I very much enjoyed picking his brains and hearing him expound on the subject of amyloid, and I hope that's been helpful to our clinical practices. I wonder if pharmacological solutions will address CNS amyloid deposition as well as cardiac and renal deposits, ultimately reducing the burden of dementia, heart failure and renal disease, which is so common in our elderly population. And this is a field of medicine that I believe is likely to hold our attention for years to come. We have another guest next week, and during the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au.